So it's the last section of the class, and then you guys will be done with me forever. Fantastic, right? I'm sure you guys are ready. It's okay. It'll be bittersweet. And but kind of happy. I get it. No, it's okay. Anywho, so the prescription assignment, the last one, I just posted it. So again, that'll be due the same day as the test. I won't be here that last day, but that'll all be due then. Everyone turn in their prescription assignments for this section. Good. Okay, I'm going to start grading those. And then we should be good. I think that's the last thing. No more quizzes from here on out. It'll just be that last test. Okay, so we'll be going over the endo part 1 here. We'll do OB-GYN stuff and then kind of a last little smattering on Jerry Peds stuff. So I'll get those lectures posted here pretty soon. Anywho, have you guys covered diabetes already? Okay, fantastic. I'm going to focus mainly on the drug management for this. And so what are the primary hormones we're going to be talking about here? Insulin, good. What else? Glucagon's the other big one. You know any other ones that are going to be important? You guys ever hear of glucagon-like peptide or heard of incretins? We're going to talk about those. Those are going to be important for a newer set of drugs we're going to be using nowadays. However, glucose is super necessary. If we run out of glucose, what do? You go unconscious, you start seizing, you die, right? Because the brain needs glucose. So if you can't regulate that, it's going to be a problem, right? And so what's going to be one of the big side effects from a lot of these diabetic medications? Hypoglycemia, right? Again, anything that's meant to drive down the glucose can potentially drive down the glucose too far. It's hypoglycemia. So we're going to talk about that and make sure that we know what these kind of side effects are going to be. And that's going to be based on the mechanism of the drug we're dealing with, whether it's going to be something that actually increases the activity of insulin. Some of them are going to be working to increase the amount of release of insulin we have. Some of them are going to work to make insulin work better, okay? Those are going to be called sensitizers. Because what's one of the big problems you run into with these like type 2 diabetics? Is it the amount of insulin they're releasing? It's a resistance, right? So again, partly it's going to be due to insulin release kind of petering out towards later stages of life. However, insulin resistance is a big problem with type 2 diabetics, right? What's the problem with the type 1 diabetic? They can't make their own insulin because they have an autoimmune reaction against those beta cells. They don't produce insulin. Guess what? They get hyperglycemic, and what do they develop? DK, the diabetic ketoacidosis, right? Because we need that insulin. What does insulin do for us? Yes, it allows for glucose to get into the cells. You know, it also allows for things like amino acids and other nutrients and whatnot. But it's super, super important to have that insulin around. Otherwise, the body has to rely on metabolizing things like fatty acids, and that makes ketones, that makes acid, that makes DKA. That's no good for your patients, right? So that's one of the big things we're going to try to avoid. But that's a frequent reason why these patients may show up at the hospital, at the ER, is due to DKA. That's for type 1 diabetics. Do type 2 diabetics usually get DKA? No, they get this other thing called hyperosmolar, hyperketotic, or hyperosmolar, I can't remember, HHS. But they will come in for, again, similarly with high glucose levels, but it's a little different. Anyway, super in depth on that. Why do we care about diabetes kind of long term? So there's macrovascular complications, there's microvascular complications, right? So what are some of the micro ones? Retinopathies. Neuropathies, right? So everyone ever see a picture of diabetic foot? Not pretty, right? Amputations happen all the time because of that sort of thing, right? Because they cannot feel when they have injuries to their feet or lower limbs, right? What about some of the macrovascular complications? Atherosclerosis, you know, that all that glucose can be pro-inflammatory, right? As you start to oxidize that glucose, it produces free radicals. You can see oxidative damage being done. Atherosclerosis happens. You can see heart disease. What happens to the kidneys? They're going to take a hit too because, again, all that glucose shredding through that glomerulus, you know, we can do a pretty good job of reabsorbing glucose from that proximal convoluted tubule, but we can only do so much. And you have so much glucose going through, eventually it's going to spill out into where? The urine. That's one of the big things. That's one of the ways used to diagnose diabetes. If they had, you know, kind of sugary urine, that would tell us that they had diabetes, right? Nowadays we do different things. What do we measure nowadays? A1C. What does that tell us?
Average glucose over the past.
Yeah, average glucose over the past 3 months, right? So again, that's basically how much glucose the hemoglobin's been carrying around in your red blood cells for that period of time. We also use, you know, fasting blood glucose and postprandial glucose levels and different things like that. But those are the main things we're using. So, and I'm not going to go into the diagnosis, but again, you guys have covered this already, so I'm not going to belabor these points. I'm not going to have you diagnose somebody on the test, but you know, these are what goes into deciding someone's diabetic and when we need to start treating them. So again, type 1 is going to be that autoimmune condition. That's where you're seeing kind of that the patient is destroying their own beta cells there, so they're not producing insulin. Type 2, though, you're going to find that do all type 2 diabetics need insulin? No, because a lot of times we can use insulin sensitizers and kind of make what they're producing work a little bit better, or we can give them drugs that actually helps them to release more insulin than they would otherwise. Some of them will go on to require those. Maybe a third of those patients will require some amount of insulin, and the types of insulin we're going to use may be a little different. The way we're dosing those patients will be a little different, as we'll see as we go forward. Okay, and again, mentioned renal failure can be a big deal, especially with type 1 diabetes, but the macrovascular issues for type 2 diabetics, heart disease is going to be one of the big things that's going to kill these patients off. Okay, so I mentioned the beta cells produce what? Insulin, good. What do our alpha cells produce? Glucagon. What does glucagon do? Raise blood sugar. How does it do that? Stimulates the liver to do what? Gluconeogenesis, and it produces it from what? You've heard of glycogen? Glycogen is a storage form of sugar, right? So again, glycogenolysis, you're breaking down glycogen. You're going to be producing new sugar, gluconeogenesis, right? So again, that's what's happening in the liver. That's one of the big things to know with glucagon is because we can give glucagon, right? So you guys probably heard that we would give like a prescription for glucagon to some diabetic. But you got to have glycogen around. What you find with some of these patients that they've been hypoglycemic for a long period of time, they've already run through all their body's supply of glycogen. And at that point, they, you can give them glucagon, won't really do anything. So again, you need to have that glycogen there in order for glucagon to do something. Okay. So again, when you see with the type 2 diabetic patient, they're basically just kind of overrunning or overworking their pancreas. Again, it's going to last for a good long time, but again, it's going to tire out at some point, right? So not only that, but you also have your cells, skeletal muscle, adipose tissue, everywhere else gets very resistant to insulin. So it takes more insulin to overcome that. And so that's why the beta cells are trying to overproduce and try to overcome that resistance. Okay, so that's one of the main targets we're going to be focusing on with type 2 diabetic patients. Or type 1 diabetic patients usually resistant to insulin. Not generally, right? You can certainly have some that will develop that over time, but typically you do not see a lot of insulin resistance in that patient population, okay? And you can imagine looking at someone who is a type 2 diabetic patient over time, you can see here that you have a lot of reserves. So you may not notice the actual amount of the actual beta cell functioning until it gets around 50% to actually get like a diagnosis. Very similar to the kidneys, you got a lot of reserve. They can kind of function for a decent amount of time with having kind of diminishing, active cells until you get to a certain cut point, and then you kind of don't have any reserve left. So I mentioned autoimmune is a big thing with type 1 diabetes, so I'm not going to get too much into that. Some people can develop a little bit later in life, but this is usually a pediatric condition that we diagnose kind of early on. Okay, so insulin. We mentioned that it comes from the pancreas, right? There's beta cells. Note here that it actually comes out as this product called proinsulin. I'll show you some pictures of this in a minute. But it comes as a prohormone that gets cleaved. There's a couple of disulfide bonds that gets cleaved, and it gets turned into the C-peptide and insulin. And C-peptide is actually another thing you can measure to see how much insulin the body's producing. But what you're going to find is that it gets cleared from the liver and about 40% through the kidneys. So what do you think this would mean for someone who has, say, renal failure? Insulin get eliminated more quickly, less quickly? Less quickly, right? So this is actually something we run into frequently, like in the ICUs. Somebody who develops kidney injury, they actually hold on to insulin for longer, and that would cause them to do what? Become hyper or hypoglycemic? Too much insulin's around. Hypoglycemia, right? So we can actually run into hypoglycemia related to that from them not being able to clear their insulin so well. So again, this will be something you want to take into account when you're looking at your patients and evaluating them. Because again, we said with type 2 diabetic patients, what's an organ that takes a hit? The kidneys, right? So again, the kidneys take a hit after a while, and that could be influencing how the insulin's handled. Normally it has a pretty short half-life. We're going to see that with modifying the structure of insulin, again, this is a protein, by changing out some of those amino acids, we can actually change the release characteristics and how long it's going to last. And that's going to be important for our drug products we're going to use. So again, basically what's happening, and I'm not going to get super in-depth on the details here, but just know that when the pancreas gets exposed to glucose, there's going to be some glucose transporters. It's going to internalize that. Glucose gets turned into what eventually to use for energy? ATP, right? It's going to help to produce ATP eventually. And so you're actually going to find it's going to close these ATP-dependent potassium channels, right? And so you're actually going to find that this is going to depolarize the cells. You get a depolarization, and it's going to open up calcium channels. Calcium is very important because that'll go into the cell and will cause these vesicles of insulin to go and undergo exocytosis, right? So they're going to go and release that insulin into the bloodstream. And so this is important because we're actually going to find that we have a drug that will affect this this pathway. They'll actually affect those potassium channels. So you guys ever heard of sulfonylureas? Like lipizide, glyburide. We'll talk about this later, but this is where these are going to be working. These actually will directly stimulate release of insulin from the patient, right? So that'll be important for side effects and efficacy. So again, imagine here you have your glucose transporter. This is a beta cell, beta pancreatic cell. You're going to have glucose come in and gets metabolized to ATP. You're going to close these potassium channels, right? So you're going to decrease that efflux of potassium out. That will cause a depolarization, then calcium comes in, and it's going to stimulate exocytosis. Okay. This is the general process for how insulin gets released. Again, we're going to see where our sulfonylureas are going to be working right here. Okay. Now, when it actually gets into the target tissues, usually it's going to interact as a GLUT4 transporter. I'm not going to get you very specific on if it's GLUT2 versus GLUT4. Don't worry about that. However, just know that when it gets over to the cells where they're going to be interacting with, it's going to be causing basically these glucose transporters to be kind of to be resurfaced on the cell surface and cause them to go up, and then that can start to facilitate glucose coming in through the cells. Right? Normally, glucose cannot go through a biologic membrane; it is impermeable. But however, when you have glucose transporters get up to the cell surface, they open up and allow glucose in, and insulin is going to be directly responsible for that. Now, some glucose can be used for ATP directly. What does excess glucose get turned into? Glycogen, right? So that's a good storage molecule. And then eventually, if you have too much glucose around, it can also get turned into adipose tissue, right? So again, that's where we see that, you know, it's one of those kind of misnomers, at least when I was growing up and hearing about nutrition, like fat makes you fat. Not really. It's usually carbohydrates, right? All the extra glucose gets eventually stored as adipose tissue, right? Anyway, this is a little overcomplicated, but just the main points to look at here. You see insulin binding to these receptors. There's actually a tyrosine kinase receptor, if you remember that back from the first pharm class we had. But this will stimulate these release of these GLUT4 transporters onto the cell surface, right? So basically, this is the main thing you're seeing here. Now, there's a lot of different ways we can affect this. Some of this is going to go for glycogen synthesis, you know, and affect things like protein synthesis. And if you think about it, insulin is an anabolic hormone, right? You know, so anabolic means what? Build stuff up. So you can actually see that bodybuilders will use insulin inappropriately to try to stimulate muscle growth and things like that. So it's definitely is an anabolic hormone. And one of the big things you're going to see when you give insulins, what does it do to someone's weight? Typically it's going to go up, right? So again, this is in a lot of your type 2 diabetic patients. Are they typically underweight, overweight, normal weight? A lot of them are overweight, right? So this is one of those things where you're going to see that anything that increases the amount of insulin activity typically causes them to gain weight. That's going to be not a great thing for some of those type 2 diabetic patients. Now, you think like a type 1 diabetic patient, do you think they're usually overweight, underweight? If anything, they're usually pretty small, right? They're usually pretty underweight because again, they have a lack of insulin there, and they're not really getting the same amount of glucose transporters being put on that cell surface. They don't have that same amount of glucose coming in. So that's kind of one of the issues you see there. So normally, type 1 diabetic patient usually pretty thin for the most part. Okay, so again, there's lots of different types here. Some are more responsible for transport of glucose in the brain. Again, you need glucose around on the brain. Otherwise, you can see altered mental status if you have hypoglycemia. Has anyone ever been hangry around here? That's mild hypoglycemia usually, for the most part. Are you pretty in a good mood, bad mood? Yeah, you're in a pretty bad mood, right? You need a Snickers. That's one of those things you can see. And oftentimes, if someone comes into the ER and they have altered mental status, the first thing we check, or one of the first things, check a glucose, right? Because again, if they're hypoglycemic, we can fix that. We can give you sugar, right? We can give you glucagon. That's no problem. But glucose is very, very important for CNS function. Okay. Let's see. So again, some of the physiologic effects we're going to see here in the liver. Normally, it's going to stimulate storage of glucose as glycogen, which is important. We want liver glycogen stores in order to use for energy later. And it's going to be inhibiting gluconeogenesis, which makes sense because, again, if you have a lot of glucose around, you don't need gluconeogenesis to occur, right? It's that negative feedback loop that gets activated here. Skeletal muscle, again, get a lot of storage. And again, you have amino acids get stored as protein, which is why you see those anabolic effects. And then we mentioned adipose tissue typically will stimulate storage there of triglycerides. You see increased fat production. Okay, so this is an important thing here because when we're giving insulin to patients, especially those that do not produce their own insulin, it's very important that we try to mimic what the pancreas would normally do throughout the day, right? So again, ideally in the future, probably near future, we're going to have like implantable pancreases that will just be able to monitor blood glucose and will be able to accurately simulate what a normal pancreas would do. We're kind of almost there in some respects, and I'll show you some examples of that a little bit later. But the big thing here is you notice here's insulin levels that happen throughout the day, here's glucose levels. Now, when do you normally see big rises in glucose? When you eat, right? Absolutely. So again, see breakfast. You normally breakfast, most important meal of the day. Get a lot of carbohydrates there. Get your toast and your waffles and whatever else. You're going to see a big spike in glucose. In response to that increase in glucose, you're going to see a spike in insulin, right? So and you can see that. You can see usually there's a little bit of a delay. As you start to have that influx of glucose, insulin goes up too, right? Then later on, you're going to see the insulin levels start to dip back down, especially as blood glucose levels start to normalize. And then when you're around lunchtime, guess what? Another spike of insulin, another spike of glucose. Okay, so as you might imagine, we're going to be giving patients boluses of insulin, similar to this in a lot of cases, right, to try to mimic what the pancreas would normally do. Now, notice here, do you ever have a zero blood glucose? No, you always got to have blood sugar around, right, in order to function. And similarly, you're never going to be at a point where you're never releasing insulin, right? You always have a basal amount of insulin being released. That's throughout the day, and it can change depending on time of day and things like that. There's different circadian rhythms that can affect that. However, you're going to see a basal amount being released, and then you're going to see a spike, okay? That's going to be important because when we're trying to replace that, like a type 1 diabetic patient, we need to mimic that. We need to give them a long-acting form that replaces that basal amount, and then we need to give them boluses of short-acting forms that replace the mealtime insulin. Okay, so this is going to be important when we're looking at the different types of insulin we have available to us. All right, so about 17 different formulations available. What routes do we normally give insulin? Do we do it orally? Don't do orally, right? It's a protein, gets torn up. Sub-Q is going to be one of the most common ones. Patients are injecting themselves. Anyone know of any other ones? You could do it IV. Occasionally do it in the hospital. There's actually an inhaled form too. It's not going to be widely used in a lot of cases because sub-Q is just what we've done for many, many years. But there's actually an inhaled form I'll show you here in just a second. The main differences here are their time of action, right? So the duration of action, how long they last, how quickly they come on. And so for instance, if I'm trying to deal with, say, a mealtime influx of glucose, do you think I want a really long-acting insulin or really short-acting insulin? You want short, right? Because again, that big spike in glucose is going to be self-limited for the most part. Versus if I want to replace that basal amount of insulin that my body would normally be releasing, you want a long-acting form, right? So that's going to be important when you're looking at different regimens here, how we're going to replace this. Now, again, we can change their kinetics by doing different things like adding zinc to it in some formulations. A lot of times what we're going to do is actually change amino acid sequence. So we can change, say like a proline for a lysine, and that will actually help to change the characteristics of it. So it's kind of cool. Because does anyone know where we used to get insulin from? Pigs. We used to get it from pigs and beef. Right, so we actually used to get it from animals that were producing it. It was close enough to what human insulin looked like, and so we could use that for our patients. Nowadays, all the stuff we have is usually recombinant, or it's formed in yeast or E. coli or something like that. So we have better ways to produce it now. Because again, some people have religious proclivities that prohibit them from getting pork-based products or beef-based products, right? So it's kind of helps get around some of that. However, there's some rare instances where you still may use it. What's another problem with using animal proteins in a person? You could also see reactions to that. So that's another kind of downside, the reason why we don't use it much anymore. So anyway, if you'd imagine here's proinsulin itself, right? So this is kind of the inactive form. You almost kind of consider a prohormone. This is that C-peptide that gets cut off, and then you would have basically this leftover insulin. That's what the actual active form is. And so we can do things like when we change out two of these amino acids here, this lysine and proline, you get insulin lispro. Or you could do something like insulin aspart. You just put an aspartate into where this proline was. And again, it's not important to memorize the amino acids that were changed. Just know that this is a mechanism that we'll try in order to change the activity of insulins, right? So I mentioned some of it used to come from beef and pork products. We really don't use that too much anymore. But nowadays, what we normally use are going to be either made from E. coli or from yeast. And so, for instance, with Humulin, so two of the big manufacturers, either Humulin or Novolin. Humulin normally makes it from E. coli. Novolin uses it from baker's yeast. That's usually just the difference between the two products. Again, similar. They're going to have very similar characteristics when you actually use it in a person. But again, don't memorize where they're actually coming from. Just know that this is kind of we're getting better sources than getting it from a pig. So be familiar with the different types of insulin we have here. There'll be a table I'll show you later on that will kind of give you an idea of what the different characteristics are. But we're going to have very short-acting insulin. This is going to be our insulin lispro or aspart and glulisine. Okay, so if you ever see like Novolog or Humalog, think log, think logarithmic, think something working very quickly. I don't know, that's how I kind of think about it. Like a logarithmic increase. I think it's a very fast increase, right? That's how I think about those working. So Humalog, Novolog, those are very common ones. Usually, if you work in a hospital, you'll have like one that is like your formulary item. So, for instance, we use Humalog over at our hospital, right? But if you go somewhere else, I don't know what they use at Florida Hospital. It might be Novolog. Who knows? Depending on whatever deals they have with the insurance company or the manufacturers. Okay, we'll have regular short-acting insulin. This one is actually going to be very similar to what we produce naturally. So it's going to be kind of a replacement for what we would normally make. And then we start to get into some more intermediate-acting and long-acting agents, right? So these are going to either be twice-a-day type agents or once-daily type agents. They're going to get to cover that basal amount of insulin we would normally be releasing, right? So you have something like an ultralente form. We have an NPH form. It's not Neil Patrick Harris. It's protamine, actually including with that. And then with the most frequent ones we're using for long-term use are going to be these glargine, detamir, and degludec. So if you ever heard of like Levemir or Lantus, this is where these are coming into play here. So I'll show you a chart and it'll show the brand names as well, because most people call them by their brand names most often. And then we actually have the inhaled forms called Afrezza as the brand name there. I'll show you that in a minute too. Okay, so this is a good table or a good chart to kind of show you the difference in activity between the different types of insulin. We mentioned the very fast-acting. Notice that they come on very quick and they leave very quick, right? They're very short duration of action, but very potent, very quick onset. Okay, so again, what would this be good for? Mealtime, right? So it's good for mealtime glucose influxes, right? Versus like regular insulin. You can also use it for mealtime, but again, it's not going to have as quick of an onset, right? And that's important when you're thinking about when to dose these medications. Normally, you don't want to dose it at the same time that you're eating. Normally, you want to do it a little bit beforehand to give it time to be absorbed and get it time to have activity. So by the time you eat, you're ready to deal with that glucose. NPH, you're going to see, has a little bit of a kind of intermediate activity. This is usually kind of a twice daily sort of medication, but the ones we use very frequently are going to be like insulin detamir or glargine. Very long activity. Notice about 24 hours of coverage. This is really good because you only have to use it maybe one time a day for the most part, right? And again, when you're giving these regimens, do you want to shoot for more injections for your patient or fewer injections? Fewer. Always want to do fewer injections. It sucks to have to inject yourself the rest of your life. Don't make it harder for them than you have to, right? This is why things like inhaled forms and other dosage forms are trying to be are very highly sought after. They kind of are not the greatest products that are out there. So again, injections are really the best way to go. But again, if we can make this less complicated, fewer injections, better off. Okay. So typically we'll have things like injections, you can draw it up in an actual syringe. You'd have a very short subcutaneous needle that you can use to inject into the patient. Where do you normally inject this at? Usually the abdomen. So again, you want to usually rotate sites because otherwise you can see some irritation that happens there. Sometimes you use the same site over and over again. You have this kind of lipodystrophy that happens very locally. So again, alternate around. That's fine. Certainly we have portable pen injectors. So these are going to be, have you ever seen an insulin pen before? Looks like a little, almost like a pen light or something like that, a little bit bigger than that. And the patient would actually dial in their dose to see what they want to administer, how many ever units, because again, insulin gets measured in units, not micrograms or milligrams, units. And when if you write that out in a prescription, do you write units? Write out units, okay? Because you could be misread as a 0 and potentially based on your handwriting. So anyway, pens, they would dial in their dose, they attach a pen needle to that, and then inject it subcutaneously. And there's a little button they'd hit on the top that would inject that. Who might that be a problem for? I think older individuals, I think people that arthritis, like rheumatoid arthritis, they have a hard time dealing with that, or their vision problems. They can't see what dose they're actually dialing in. These are things you have to consider, like how able are they going to be able to administer their own insulin in these cases, right, based on your patient. Honestly, you're going to find that like kids are the absolute masters of this stuff. They can handle their diabetes better than most of us will ever be able to because they do it every single day. Like that's their life, like that's what they do. And so for those type of patients, we have these kind of continuous subcutaneous infusions, right? So this is what one of the first insulin pumps used to look like. Does anyone want to carry that around? Maybe they're doing like their Ghostbuster cosplay or something, but yeah, so this is pretty complicated. Nowadays, we have very small, little tiny pumps you can just hang on to your belt loop, and you'll have noticed the subcutaneous catheter gets placed there. Normally, we'll put the insulin into this this device, and they can program in what their basal amount of insulin to be released is, right? So they can say, I want this many units per hour, and then when they have an influx of glucose coming in, snack time, meal time, they can program in a bolus. They program it in based on how many carbohydrates they're going to get, program it in, and boom, they get their bolus. What type of insulin do you think we'd want to use with this? Yeah, usually rapid acting or regular insulin. Most often I see the rapid acting, Humalog or Novolog, because again, when you're doing a continuous infusion, you want short acting agents because you want to be able to titrate that very quickly, right? Because again, if I give too much of it on accident, I want to be able to take that off, turn it off, and get the effects away quickly. If I'm using a long acting agent in there and I get too much, guess what? It's 24 hours. I'm going to be sticking around with that. So again, insulin errors are huge. Huge. Do not screw around with insulin. This can definitely kill somebody, okay? So there's been lots of errors where we can do things. I'll show you some error-prone issues a little bit later on. But now, are these devices perfect? they can malfunction. We see a lot of kids that will come in, they're going to be coming in for like device malfunctions where it's either not giving them enough insulin, which is more common, so they come in hyperglycemic, maybe on the verge of DKA. I don't know that I've seen one that actually was giving too much, but I imagine that could be a potential issue if they maybe misprogram it or something. So again, who do you think would be a good candidate for this? So someone who's like maybe a brand new new diabetic? Not typically, no, because you need to figure out how they're going to respond to insulin. Everyone has what we call an insulin sensitivity factor. So again, you're going to find that they'll have this factor, and you can calculate this out, that how many carbohydrates, how many grams of carbs they get, they will respond to with a certain number of units of insulin based on their sensitivity. And so you need to figure that out. It takes time. It takes a lot of time to kind of tinker with their insulin regimens to kind of figure that out. So this is not good for someone who's brand new. How about someone who's like non-compliant with their medications? They're not going to be good for that either, right? So again, these are really good for, like, especially younger patients, especially those who are very well managed, their A1C is in check, they don't have any compliance issues, and can accurately describe to you, like, okay, I'm going to calculate this, I'm going to get this many carbs, I'm going to give this many units. Like, that needs to be a very responsible patient, because otherwise, if you screw up with this, that can go wrong pretty quickly, right? So again, it needs to be a very good, well managed, controlled patient, usually. This is an example of the inhaled form. Notice you'd have a little cartridge of insulin here, and basically it looks like a little tiny, like kind of fake cigarette or replacement cigarette kind of thing. But they could inhale that, and the lung would be vascular enough and well enough able to absorb that insulin, and you can get some effect there. Again, it's going to be more variable because, again, what's one of the big issues with inhalers? Technique is super important. So if they have bad technique, they're either going to get it all in the back of their throat, where it's not going to do any good, or they may not really get a good deep inhale. So, COPD patient, maybe not great for that, right? Because they may not be able to really kind of have a good inspiratory phase there to actually get the drug. So most patients will be managed with subcutaneous injections. So again, here's some of the brand names you're going to see associated with these. The long or short-acting, rapid-acting forms, like I mentioned, Humalog, Novolog, and Apidra. These are very short-acting agents. Again, good for meal times, right, or good for continuous infusions for like a sub-Q pump. You don't need to memorize the dosing options that are available. It's just more for kind of your reference. But normally they come either as a pen, which again, pens are very convenient for a lot of patients, or they come in like a vial that you could actually draw doses out of. Now, how do you need to store these products, do you think? You need to go in the fridge, right? These are proteins. If you leave them out in your dash in the hot summer, right? Nowadays it's been a little cooler. Maybe you could store it for a period of time. But if you leave it out in your dash in the middle of the summer, this stuff's going to denature. It's going to be no good, right? You're wasting a bunch of money. So make sure they know to store it in the fridge. Usually these patients are pretty good with this for the most part. Okay, so mention our normal acting regular insulin. These are going to be Humulin R, Novolin R. So again, that just goes back to which brand, which company is making them. And then we'll mention the long acting forms. The ones that I see most frequently are going to be like Lantus, like insulin glargine, Levemir, and this Tresiba. This is kind of the newest long acting form that's out there. Now, if you had to think like a type 2 diabetic patient, which type of insulin do you think you'd want to start them out on usually? Usually you're going to do a long-acting form because, again, if you think about it, like their issue is kind of this long-standing insulin resistance. They're kind of wearing out their pancreas over time. They need kind of a bump in their basal amount of insulin they have kind of working 24 hours a day. And again, this is usually going to be a one-time injection for them. Some of them need to move on to have mealtime insulin as well, but we try to hold that off as long as we can because, again, compliance is an issue. We don't want to overcomplicate the regimens. If we can just do a one-time daily long-acting form, that's great. However, with like a type 1 diabetic patient, you're giving all their insulin to them exogenously. You need to do mealtime and you need to do a long-acting usually. So I'll show you some regimens here in a few minutes of what that looks like.
So that's just to increase their basal.
Right, because again, yeah, so they probably still have issues dealing with postprandial glucose, but you can try to target one issue first and that they still need that extra help, then you can kind of add that on. But again, insulin is something we like to hold off on for those type 2 diabetics if we can. We'll go over those drugs a little bit later, probably next class session if I had to guess. But and then there's some mixes that are available. This would be good for including like a long-acting or intermediate and a short-acting form. Some people will use that. And then here's another big problem that we're running into. So sometimes patients are so insulin resistant, you need to use more concentrated forms of insulin. This is huge room for medication errors because if you screw it up and give someone U500, which is 500 units of insulin per ml versus usually most insulin is U100 or 100 units per ml, guess what? They're going to get hypoglycemic, right? So you can fix that. You can give them glucose, but it's going to be tough to fix that in a lot of cases. There's U200, 300. Just be very careful when you're mixing these up. If you ever need to prescribe one of these, be very careful because it's kind of a loaded gun in a lot of cases. Okay. And so you can kind of get an idea. Don't memorize these numbers necessarily, but just know that, okay, I think rapid acting, be able to recognize if one's rapid acting or not versus long acting, and know, okay, yeah, onset is pretty quick within an hour, peak effect within 1 to 2 hours. And those are kind of like general general things to recognize about these. That, yeah, they're short acting, they're good for meal times versus long acting forms. They're good for 24 hours usually. They're going to be better for kind of basal insulin replacement. Okay, so I mentioned complications of insulin. Mainly the thing is going to be hypoglycemia, especially if you give the wrong concentration. Most of the time you're going to use that U100. Again, U is not a good abbreviation, usually right at units, but actually some of the packaging still has this, so is what it is. In some cases, you may actually find patients could have an allergic reaction to their insulin. Rare, but it does occur occasionally. Oftentimes, what you may run into over the long term is it will activate, they'll generate antibodies against the insulin that will just inactivate it, right? So remember how we were talking about using like infliximab for something like rheumatoid arthritis, how eventually your body can generate antibodies against that when it inactivates it. Remember how we give like methotrexate to try to overcome that? The same thing can happen here, right? So potentially by switching insulins, you may be able to overcome that, but it just depends on the patient and when they're having that issue. Other things, injection reactions, you can try to warm up the vial because most of these should be stored in the fridge for the most part. So try to warm it up, and that helps with some of the pain associated with that. I mentioned rotating sites to avoid that lipodystrophy. You want to watch out for that. And then weight gain is a big thing. All these patients are going to put on some amount of weight when you start them on insulin. It's going to be kind of just that's how it goes. So let them know, hey, for type 1 diabetic, not a big issue most of the time. Type 2 diabetic can be a bigger problem for them. So again, let them know, hey, you're probably going to put on some weight. We need to monitor for that, but we need to make some other adjustments elsewhere to maybe overcome that. So we'll see that can be an issue. Okay, so things that can maybe decrease the hypoglycemic effect of insulin, these are things that may interact. So things like corticosteroids. You remember what corticosteroids did to blood glucose? Right. So again, same thing, oral contraceptives. We'll talk about that in the next section here, but that can also have kind of a pro-glucose sort of effect. Usually any kind of like stimulant type drugs like epinephrine, dobutamine can potentially stimulate that. Thyroid hormone potentially could cause hyperglycemia. So these are all things that may kind of diminish the effect of insulin. So these are things to watch out for. Things that may increase the hypoglycemic effect of insulin. Alcohol. Alcohol typically will cause you to become a little bit more hypoglycemic. This can interact with insulin. Things like beta blockers, monoamine oxidase inhibitors. So again, just know that there's lots of interactions that are out there. Just watch for that. And again, you can adjust your insulin dose to overcome these if patients need to be on those other medications. Okay, so our indications for insulin, type 1 diabetic, right? We got to replace our insulin, makes sense. We will sometimes use this for patients who are pregnant who need glucose control. They cannot manage it with diet alone. We will sometimes give them insulin because, again, that's going to be one of the more safe things to give a pregnant patient because it's usually what we produce anyway. And then for a type 2 diabetic patient, if they're not controlled by diet, exercise, or the oral medications, then you're going to utilize insulin for these patients. Usually kind of a last resort for a lot of them. Diabetic ketoacidosis is an absolute deficiency of insulin. This is where you need to replace that. So most patients who come in for DKA need to be given an insulin drip, along with usually a glucose infusion, along with a lot of potassium and things like that they've been losing. So again, that's going to be a main indication like in the ER. And then we use it for this hyperglycemic hyperosmolar non-ketotic syndrome. This is what type 2 diabetic patients develop occasionally. It's kind of like their version of DKA. They don't really get as acidotic, but they get very hyperglycemic. You can see glucose. Like, what's a normal glucose? 80 to 100, maybe 120, somewhere around there, right? These patients get like 3, 4, 5, 600 glucose, no problem, right? They get very, very hyperglycemic. And then hyperkalemia, this is another thing we won't talk about too much here, but just know that can also help to drive down potassium because as it causes an inward flux of glucose in the cells, it also does that with amino acids, does it with potassium as well. So occasionally we'll give this for hyperkalemia. Okay, so the regimens need to be tailored to the patient's lifestyle. Do you guys mind if I go to 10 just to try to make up for some lost time? You guys have anything after this? Yes. Okay. Well, I'll go to 11 then. Just kidding. Okay. So things need to be tailored to the patient's lifestyle, right? So you try to make sure it's going to be most convenient for that. We're going to use a basal bolus regimen. That means that bolus is going to be for the meal times. The basal is going to be for that kind of daily 24-hour sort of replacement there, right? It's going to be with self-monitored blood glucose readings. So they're going to have to stick themselves pretty consistently to get their blood glucose monitors. Now, are there any other ways to monitor blood glucose these patients? They have to stick their fingers all the time? There's starting to be some different ones. There's actually subcutaneous sensors that they can actually put in. Sometimes those are a little bit slow to equilibrate with what the actual blood glucose is, but that is one thing you try doing. I know there's certain sensors that are working for actually in the eye that would actually be able to detect glucose levels. So there's things that are going to be coming out there eventually, but most of the time people are going to have to stick themselves. It stinks, no fun for them, but it's kind of what they have to do, right? And often they're going to have multiple daily injections, try to mitigate that if we can. But if you think, kind of the easiest regimens you could be on would be, long-acting forms. That's 1 time in the morning and then 3 times for meals, right? So it's at least 4 injections you're having to do in most cases. So again, if anything you can do to minimize that's great. If you give more injections, that'd be offering better, glycemic control, but it's more complex, less likely to be compliant with that. Less often, though, you're going to see more chances for hyperglycemia, but also lesser chances for hypoglycemia. It's kind of a double-edged sword. You got to find the happy medium for these patients. Okay, so oftentimes you're going to need to match carbohydrate intake along with their insulin, right? So for instance, if I skip a meal, do I need to have insulin for that? Glucose is not in flux. Right, so again, they skip a meal, skip their insulin dose, okay? Oftentimes they probably shouldn't skip meals, they probably should be eating. Again, this is type 1 specifically. What do you think exercise would do to insulin demands? It would raise it? What am I doing when I'm exercising? Am I utilizing a lot of glucose? It actually goes down, right? Because if I'm exercising, I'm using a lot of glucose for energy, right? So I don't necessarily need as much insulin in those cases. So again, they need to be able to tailor that. And everyone's going to be a little different. They're all kind of snowflakes in some respects. So you have to make sure you're kind of tinkering with it to get it just right. And so, endocrinologists and diabetes educators, they take a lot of time to work with these patients to get things just right. Because again, if you screw it up, you got hypoglycemic, no good. If you screw it the other way, you get hyperglycemic. It can be a problem in the long term. So again, ideally, insulin administration should mimic the pancreas as best you can, as I kind of mentioned with either the sub-Q pump or something like, basal bolus sort of regimens there. And again, look at the onset of the drugs, look at the duration of action, the peak effects, and try to match that with what their lifestyle is like. And I'll show you a picture of that in a second here. Okay, so again, normally we try to mimic this. So again, at a minimum, you'd like to get long-acting formulation that would kind of have that basal insulin effect, and then we would want some peak effects with short-acting drugs to go along with that. So again, at least looking at 4 different injections just for that. I'll show you some other regimens, and I think the next slide here, maybe not. I think I have a slide come up in a second. I'll show you some examples. But generally, as I mentioned, you need to modify with carbohydrate intake what their insulin dose is going to be. So for instance, they will do one regimen called carb counting. You guys heard of carb counting? What is that?
You're going to eat something. This is for carbs.
So if I get 10 carbs, 10 grams of carbs, then I'm going to match that up with this many units of insulin, right? And that's based on an insulin sensitivity factor they have, right? So that's called carb counting. That's one method of doing things. What about a sliding scale? What do you think that means? Yeah, so that's going to be usually more reactive because you're actually adjusting your insulin dose based on what your actual blood sugar is, okay? So for instance, the sliding scale, that's why it slides, because you say, okay, from, say, a blood glucose of 100 to 200, I may do 1 unit. For 2 to 3, I might do 2 units. 3 to 4, yes, ma'am?
Before you eat that, like, I'm going to eat this much. So
it's going to be after you check your glucose, right? So you may check it, say before the meal and say, already I'm at this level. I know I'm going to get this many carbohydrates. Sometimes they'll incorporate kind of both regimens in there. It just depends on kind of what they're doing. But basically, they'll be able to determine with their correction factors how many carbohydrates that 1 unit of insulin can fix, and they can adjust it from there, right? That will change over time. It's going to be a little different for every patient, but you can adjust for that. So here are some examples of different regimens you may see. So here's normal glucose levels kind of throughout the day. Again, notice you have basal glucose amounts. Again, here's going to be our mealtime boluses, right? Here's our insulin levels. Here's what would normally be occurring in most patients in response to that, again. And so here's some different regimens we can try to do to try to replace that. So here would be an example of, say, a less complicated regimen, but you're going to find you have less kind of tight glycemic control. I mean, you're going to have kind of bigger peaks and bigger valleys associated with this. And this would be a case where we're going to use regular insulin along with an NPH. We said NPH is more intermediate acting. So notice here they had, say, 1 injection where they would mix the 2 together. They get the kind of the regular effect here. And then they would also have that NPH would be kind of long-acting throughout the day. So this would be a 2-injection regimen. But again, it's not going to be super tight control. You may not see the A1C really get in a line like you want it to. But that is one way to do it, okay? Other ways we can do it are going to be with more frequent administration. So for instance, if we use an ultralente form, which is a long-acting form, that would kind of give you 1 injection here that would be kind of long, kind of replacing that basal amount of insulin you'd be releasing. And then you have regular insulin on top of that, kind of doing for the meal times. It's one way to do it. And then here would be an example of an insulin pump. Notice here it's kind of taking care of both things with just one type of insulin, usually regular or like a Humalog or Novolog or something. Okay, this is the ideal method, but again, it's not good for every single patient that's out there, right? Most patients are going to require something more kind of similar to this. And nowadays, and this is probably kind of outdated a little bit, but nowadays what we're mostly doing is a long-acting form, so like a Lantus or a Levemir, plus usually a short-acting form like an Apidra or Humalog or Novolog. Okay, those are usually the most common regimens I see, at least. And again, I'm more skewed towards a lot of pediatric population where we see a lot of those type 1s anyway. Okay, so looking at just dosing requirements. So again, looking, and don't memorize the dosing requirements here, but these are just kind of for your reference. So with a type 1 diabetic patient, you're starting off, so you have a new diagnosis. Say I want to do, say, 0.5 to 0.6 units per kilo per day. Why do you think it's so much higher for type 2 diabetic? Not the overweight, because again, we're taking the weight out of it, right? Because we're already dosing it based on kilograms. They're resistant, right? They have a lot of insulin resistance. So they need a lot higher dose of insulin. That's why you have a lot bigger range there, and why you need to start higher than you would for type 1. Typically, what you'll do is you'll divide the regimen. 50% as the long-acting for your basal, and then 50% is regular or rapid-acting insulin. How you would break that up. So say, for instance, you have like a 40-kilo female patient with type 1 diabetes. Say, okay, I want to do a total insulin dose of, say, 0.5 units per kilo per day. So it's going to be 20 units per day. Okay, so that means how much would go to my basal insulin? It'd be 10 units, right? So I do basically, I'm sorry, yeah, so this one's a BID regimen. So you do 5 units of insulin detamir twice a day. So again, that 10 units is 50% of their regimen, right? See, most people, you try to do them on Q daily sort of regimen, but let's say for this instance, we're doing BID. And then the other 50% gets divided up amongst the meals. So for instance, they eat the kind of the biggest carb load at breakfast, which a lot of people do. They may get 4 units of insulin lispro with breakfast, 3 units with lunch, and then 3 with dinner. Some people also add on like a before bedtime sort of level. They'll actually check their glucose and kind of do a sliding scale sort of thing around there, just to make sure they don't get kind of overnight kind of hyperglycemia associated with that. So again, just know they're all snowflakes, and again, not in the derogatory sense, but they're all in the sense that they're all going to be a little different. You need to adjust to make sure you kind of fit their lifestyle, fit their insulin sensitivity. Okay. So I mentioned the pumps need to be really for good control patients. They need to be well controlled on a sub-Q regimen. They need to be someone who is able to handle all that training, right? So again, for an elderly demented person, not a good regimen for them, right? They need to probably have someone give them their sub-Q injections. But like young kids, I've seen kids, 7, 8, 9, 10, like they know this stuff backwards and forwards. And one of the things we do in the hospital when they come in on these pumps is we need to make sure they use it appropriately, because otherwise the nurse isn't managing it, parents aren't managing it, it's just them. So we have to go in and interview them and say, okay, well, can you tell me how you operate this thing? And they know way better than I do. So I'm like, oh yeah, tell me how you would do this. And they're like, beep, beep, beep. And then it's like, they're playing with their iPad or something like that. They know it backwards and forwards. They're very, very well versed with this stuff. So not everyone's going to be great like that, but again, a lot of training is needed to make sure they're using it effectively. Okay, so what do we do for hypoglycemia? What do you consider hypoglycemia? Yeah, usually less than 60, less than 65, somewhere around there. And again, you're going to find that a lot of patients, and again, when you get hangry, you go to eat something, you just eat like very reasonable, I'm going to have just one snack. No, you do overeat. Blood glucose goes sky high. A lot of people tend to overcorrect, and so normally what we do and again, this is for someone who's still conscious, someone who's still with it. They notice they're hypoglycemic. What are some signs and symptoms of hypoglycemia? Irritability is a big one. Sweating, shaking, right? That sympathetic nervous system, headache. Sympathetic nervous system really kind of getting upregulated a little bit there, right? So again, they kind of feel it. That's why we talk about beta blockers masking that. So it can be dangerous because if they don't feel it, they may not know they're hypoglycemic until it's too late. Anyway, so what we do is a rule of 15. Basically what we do is 15 grams of simple carbohydrates. When I say simple, what does that mean? Easy to break down, easy to utilize very quickly, right? This isn't like wheat bread or brown rice or something that is more complex and harder to break down. These are things that are quick and easy, right? So either glucose tablets, orange juice, milk, anything like that is very quick, easy to use glucose, or sugars that can be broken down into glucose. So either 8 ounces, 1 cup of OJ, or 4 glucose tablets. They'll take that in. They'll check their glucose in another 15 minutes to see what it is. If it's still less than 70, then they can repeat that. Okay. So that's one way we can do it. And again, that patient needs to be still conscious and still kind of with it and able to tolerate oral agents. Okay. That's one way we can do that very easily. On the other hand, though, what might else we have to do? Sometimes if the patient's unconscious, we have to give them something else. So in these cases, we can give glucagon. And so this is an example of a glucagon injection. And someone kind of made mention of this already to me in a message, but they said, yeah, they told us whenever we're giving out insulin, we need to give them a prescription for glucagon as well. And a lot of times you will do that. And so basically, this is going to be the same synthetic stuff that we produce ourselves. We're just going to inject it subcutaneously, and that should raise blood glucose. Not going to work if you don't have glycogen around. Okay, so again, someone who's been hypoglycemic for a while, they're not really going to get a lot of effect out of this. Okay, big thing to note here, though, it's going to cause a lot of nausea and vomiting. Okay, people are going to throw up when they have this. One thing we'll actually also use this for, you may see this in the ERs, if we have someone who comes in with a foreign body ingestion, like say a kid that ate a battery or a penny or something like that, and it's stuck in the esophagus, sometimes we'll actually use this to lower the lower esophageal sphincter tone and try to pass it. Usually if it's like overnight and the GI docs don't want to come in, they'll try to do that, otherwise they have to come in and scope the kid. So occasionally see that, it doesn't work all the time, but that's one other thing you may see. Okay, and then finally, if you had nothing else, what could you use to replace the blood glucose? We'll give dextrose, right? So we have things like D10, D25, and D50. These are higher concentrations of what you would normally see, because like normal concentrations of dextrose and like IV fluids is what? D5, right? We're going to higher concentrations of that, otherwise we'd have to give too much volume. It's not going to be good for them. Things like adults, things like D50. For kids, usually D10 or D25. High glucose concentration, high dextrose, is very irritating to the veins, and so D50 is usually for adults. Here's kind of a typical dose. You don't have to memorize that. Just know that we're typically going to use anywhere between 25 to 50 grams of glucose IV, and then they'll, again, you recheck your glucose, see how they're doing. Hopefully they've regained consciousness, whatever it happens to be. But just think about what you need to use based on the situation. So if someone's found down, and you're trying to give them a glass of OJ, is that going to work? Nope, not going to work, right? Probably going to aspirate it. It's not going to be not good when you cause them respiratory distress syndrome on top of their hypoglycemia. So again, think about it. They're conscious, they're with it. They can use the oral rule of 15. Otherwise, you got to use glucagon or dextrose. Okay, so any questions on that? That's the main way you're going to be managing your type 1 diabetic patients. Think about when you're writing scripts for these guys, they would also need things like needles. They would need syringes. They need testing supplies. So they need like strips. They need blood glucose monitors. They need the lancets to actually prick the fingers. They requires a ton of stuff. So anytime you have a new diabetic patient, you at least have like a dozen scripts for different things you're having to fill for them. So it's quite a bit. But again, that's why education is so important. Make sure they know kind of what they're doing and get them properly managed. Okay. So we'll continue on the next time with the type 2 diabetic stuff of those other meds, and then we'll go from there.